BPH. Etiology. Between 40 and 50, benign hyperplasia grows slow until death. Androgen or estrogen ration, chronic inflammation, autocrine, paracrine growth stimulating and inhibiting factors, age-related circulating androgens associated with enlargement. Risk factors: hyperplasia, fat, obesity, and abdomen. Aging, 4th, 6th, and 9th decades. Clinical manifestations: enlarged prostate, tissue covers urethra, LUT symptoms, delay in stream, frequency, decrease in urinary force, urine retention with overflow incontinence, increased intra-abdominal pressure, hematuria, bladder or kidney infection, bladder calculi, hydroureter, hydronephrosis, renal insufficiency. Treatments: PSA, rectal exam DRE, alpha adrenergic blockers, prostazoin or tamsulosin, they relax smooth muscle. Androgen agents, Proscar, it blocks androgens and shrinks the prostate. Interstitial laser treatment, transurethral radiofrequency or TUNA, transurethral needle ablation, or cold thermotherapy. Prostatitis. Category 1 is ABP or acute bacterial prostatitis. Category 2, CBP, chronic bacterial prostatitis. Category 3, CPPS, chronic pelvic pain syndrome. Category 4, asymptomatic inflammatory prostatitis. Etiology. Category 1 or ABP is a UTI. Category 2 is chronic UTI. Risk factors. Category 1, cystoscopy or catheterization. Category 2, chronic UTIs. Category 3 is linked to backflow of sterile urine into ejaculatory ducts. Pathogens. For Category 1 and 2 is enterococci or enterobacteriaceae from the GI flora. For Category 3, it's E. coli and P. aeruginosa and H. pylori. Immune, inflammatory, neuroendocrine, and neuropathic etiologies are for Category 4. Clinical manifestations: inflammation of the prostate. Category 1 is swelling or tenderness, firm or boggy prostate. Narrowing stream, edema causing obstruction. Category 2, frequency, urgency, dysuria, perineal pain, lower back pain, sexual dysfunction, arthralgia. Prostate is fibrotic, it's firmer or boggy, and it's a regular shape. Category 3, the symptoms are less intense for 3A, and 3B is non-inflammatory. Diagnosis: Category 1, malaise, the decreased back pain, perineal pain, painful ejaculation, fever, chills, dysuria. You can do a urinalysis. In Category 2, you massage the prostate, collect secretions. You sample the first 10 cc's And if it's got greater than 10 WBCs per high power field, then it's infection. Category 3, no bacterial source for 3A. Diagnosis is after all else is ruled out. Category 4 is asymptomatic with positive WBCs and positive bacteria. Treatment. Catheters are contraindicated, suprapubic cath if needed, and antibiotics. Phimosis or paraphimosis. The prepuce or the foreskin is too tight. The foreskin is retracted away from the glands. Phimosis, the foreskin cannot retract back over the glands. Retraction is normal in infancy. Lesions separate naturally in the first 3 years. Risk factors: poor hygiene, chronic infection, and those things also cause an increased risk of penile carcinoma. HPV is present in 60% of penile carcinomas. Clinical manifestations: edema, erythema, tenderness of the prepuce, and purulent drainage. Treatment is eradication of bacteria, circumcision, surgery if unable to retract manually, and that would be a surgical emergency. Peyronie disease or bent nail syndrome. Fibrosis causing lateral curve during erection. There's no pain when flaccid. Vasculitis. Inflammatory process, decreased tissue oxygen causing fibrosis and calcifications. There is spontaneous remission in 50%. Risk factors: middle age. Dupuytren contracture, so the flexion deformity of fingers or toes. Diabetes, keloid development, and rarely with beta blockers. Clinical manifestations: it's slow developing, tough fibrosis thickening of the fascia and the corpora cavernosa, palpable dense fibrous plaque on the dorsum of the shaft, painful erection, painful intercourse, poor erection distal to the issue, impotence, and unsatisfactory penetration. For significant deformity, then it's surgical intervention. Priapism, prolonged erection. It's uncommon. It's not associated with sexual arousal, and it is a urological emergency. Up to 50% has erectile dysfunction after. 60% is idiopathic. The rest is spinal cord trauma, sickle cell disease, leukemia, pelvic tumors, infection, penile trauma, and of course you can get it with drugs to help with erection. It's painful. Treatment within hours to prevent impotence. You can use ice saline, enema, ketamine, spinal anesthesia, needle aspiration of blood from the corpus, catheterization, and pressure dressings to maintain decompression, vascular shunts to maintain blood flow. Blanditis, inflammation of the glans, penis. Risk factors: prostatitis, it's usually in conjunction. Inflammation of prepuce, both together, is called blepharophysitis. Poor hygiene, phimosis, skin disorders such as psoriasis, leishman planus, and eczema. candidus, and diabetes. Treatment is microbials and then circumcision. Clinical manifestations, smegma, which is an accumulation under the foreskin of glandular secretions. Pathogens are sloughed epithelial cells, Mycobacterium smegmitis. Pyelonephritis. Microorganisms split urea into ammonia, alkaline urine, stone formation. Dissemination also into bloodstream. Inflammatory process involves pelvis, calyces, medulla of kidney. WBC infiltrate causes the symptoms. Progression leads to kidney failure. Obstruction prevents elimination of bacteria. Risk factors are kidney stones, vesicouretal reflux, pregnancy, neurogenic bladder, instrumentation such as a catheter, female sex trauma. The most common is reflux and obstruction from the bladder. It's primary in women. It could also be drug toxicity from NSAIDs, ischemia, irradiation, and immune complex diseases. The pathogens are E. coli, and then from surgical instrumentation would be Proteus and Pseudomonas. Clinical manifestations, inflammation, edema, purulent urine. Severe can have localized abscess in the medulla extending to cortex, affecting tubules. Necrosis of renal papillae can develop, acute with fever, chills, flank or groin pain, frequency dysuria, costovertebral tenderness. Older adults get malaise and fever. And you can get hypertension, frequency, and dysuria. Diagnosis is urine with culture, WBCs, and casts in renal tubules flushed into the urine, but not always present. Treatment, after acute phase, healing occurs with fibrosis and atrophy of tubules. Antibiotics for 2 to 3 weeks of microorganism-specific antibiotics, IV pylography, and voiding cystocurography. And if there's an obstruction, it must be relieved. Cystitis. Bladder is the most common site of UTI. Mild, hyperemic. Hemothoragic is diffuse mucosal hemorrhages, increased inflammation. Suppurative is pus. Ulcerative is sloughing and ulcers. Gangrenous is necrosis. Pathogens, E. coli is the most common. And then secondary would be staph saprophyticus. Lesser would be Klebsiella, Proteus, Pseudomonas, fungi, viruses, parasites, and tubercular bacilli. Schistosomiasis is the most common parasite associated with bladder cancer. Treatment, uncomplicated, is 3 to 7 days of antibiotics. Complicated, 7 to 14. Diagnosis, urine culture greater than 10,000 in fresh void. Leukocyte esterase nitrates. Obstruction is antibiotic sensitivity. Relapse, urine culture 1 week after treatment, and Q month for ×3. Clinical manifestations, inflammatory response, frequency, urgency, dysuria, suprapubic and low back pain, hematuria, cloudy urine. The most severe is hematuria, cloudy urine, and flank pain. Tumors. Transitional cell carcinoma is the most common. METS is usually bones, liver, lymph, lungs. TNC is used for staging. Secondary cancer forms from invasion from bordering organs, cervical, and prostate. Risk factors: men over 60, smoking, occupational chemicals, exposed to aniline dye, increased levels of arsenic in drinking water, increased consumption of phenacetin, uroepithelial schistosomiasis, that's that parasite we just talked about, genetic predisposition. Pathogens. Transitional cell is the most common. Less common is squamous cell and adenocarcinoma. Clinical manifestations: gross, painless hematuria, bothersome LUTs, daytime frequency, nocturia, urgency, urge incontinence, flank pain if obstruction. Diagnosis is through cystological studies, cystoscopy with tissue resection, and biopsy to confirm. This is usually in the first stage. Biological markers. Treatment is transurethral resection, laser ablation, chemo, immunotherapy, radical cystectomy, urinary diversion, and chemo for invasive tumors. Glomerulonephritis. Primary direct injury is isolated to the kidneys. Secondary is related to system disease such as diabetes, hypertension, toxins, lupus, CHF, and HIV. Swelling and proliferation of mesangial cells. Expansion of the Bowman space causing crescent shape. The crescent shape compresses capillaries, decreases blood flow. Hypoxia, decreased hydrostatic pressure. Alterations in filtration. Severity related to duration of antigen exposure. Risk factors: hypercholesterolemia, proteinuria, especially in chronic, it's associated with chronic, diabetes, and lupus. So the lesions are diffuse is uniform, focal is only some changes spread out, segmental is changes in only one part. Mesangial is immunoglobulins. Membranous is thickening. Proliferative is increased glomerular cells. Sclerotic is scarring. Crescentic is increase in the Bowman space and changes the shape to the crescent. Pathogens. Immune mechanisms: damage to glomerular capillary filtration system. Most common antigen is antibody complexes related to activation of inflammatory response. Further injury releases cytokines that decrease the surface area. Clinical manifestation: oliguria, less than 30 cc's of urine, hypertension, renal failure, sediment, and more severe hematuria with RBC casts, proteinuria greater than 3.5. Albumin is the major protein. Diagnosis: UA with proteinuria, RBCs, WBC, and cast in urine. Biopsy: it can be crescent shape under micro, decrease creatinine clearance. Treatments: prevent or minimize inflammation, correct accompanying problems, antibiotics, corticosteroids, cytotoxic agents and anticoagulants. Nephrotic syndrome is more common in children. Risk factors are glomerular injury, significant proteinuria, hypoalbuminemia, edema, hyperlipidemia, lipiduria, systematic disease such as diabetes, lupus, Henoch-Schönsten purpura, NSAIDs, vascular disorders, infection, and malignancy. Excrete greater than 3.5 grams of protein per day. Albumin exceeds tubular reabsorption. GERD, reflux of acid and pepsid or bile salts, may trigger asthma or chronic cough. Physiologic reflux is asymptomatic. NERD, symptoms with decreased injury, so functional heartburn. Eosinophilic esophagitis is idiopathic chronic inflammation of esophagus. Risk factors: older age, obesity, hiatal hernia, drugs that relax the LES, anticholinergics, nitrates, calcium channel blockers, and nicotine. Gastroparesis, gastric or duodenal ulcers. Pathogens, abnormalities in the LES, and delayed gastric emptying. Clinical manifestations: heartburn, acid reflux, dysphagia, chronic cough, asthma attacks, laryngitis, increased abdominal pain within 1 hour of eating, increase when lying down, acidic foods are painful. Diagnosis: history of clinical signs and symptoms. Endoscopy shows hyperemia, edema, erosion, and strictures. Barrett's esophagus is found with biopsy. Treatment is PPIs are number 1, histamine 2 receptor antagonists, prokinetics, antacids, lose weight, stop smoking, increase head of bed 6 inches, laparoscopic fund application. Hiatal hernia, diaphragmatic hernia with protrusion into part of the stomach, into the diaphragm, into the thorax. Sliding is stage 1, most common. Proximal portion moves into thoracic cavity. Paraesophageal is number 2. It's the hernia of greater curvature of the stomach. Mixed is number 3. It's less common. Mix of both. Risk factors: type 1 is congenital short esophagus, fibrosis, excessive vagal nerve stimulation, weakening of the diaphragm muscles, GERD. Type 2, strangulation and hernia is a concern. Clinical manifestations, often asymptomatic, and then symptoms are associated with other disorders. Diagnosis: radiology, chest x-ray, barium swallow, endoscopy, high resolution manometry, whatever. Treatment is mostly conservative, small meals and frequent. Avoid recumbent position after eating. Avoid tight clothing, decrease weight, antacids, and increase the head of bed 6 inches.